interested, just as our attention was caught up during Boris Chaumet's presentation. I will ask you to put on your headsets because the next presenter will be online. We're going to look at the lower part of the star that Boris Chaumet was mentioning, as we are going to have a look at ADHD with a professor from the University of Montpellier. Hello, Diane Purper-Ouakil. Yes, hello. Sorry not to be with you in person, but I'll do my best from here in Montpellier, in the south of France, and where the weather is nice now.
On vous avait devant vous, si je puis dire, dans cet auditorium de Sainte-Anne.
You have here more or less 150 people wearing a headset and listening to you. Okay, thank you, says Mrs. Purper-Ouakil. And there's a translation into English and Spanish. A majority of French people here in the room. You can switch to the right channel. Diane, is it okay for you? Yes. We can hear you in French. So there's translation into English. Can you hear? Yes? Sorry, Diane. We have to make sure everybody hears. So it's 2:25. Can you speak for about 20 minutes plus 5 minutes for questions? Is that okay? Well, thank you very much. Thank you. So we're going to go into details. Boris Chaumet has given you quite a lot of elements about attention disorders. So we're going to speak rather quickly on the main symptoms. It can be attention disorder, being impulsive or hyperactivity to a variable degree. Sometimes you have mainly attention or a mixed presentation. They're not just children that move a lot, but children that where this has a negative impact on the school environment, the family, or socially. So we have to try and see what's happening for them. So apart from these main symptoms, we have noticed that the disorders are really in the field of a self-regulation, really, about motricity or attention or emotional expression, emotional reaction or sleep or food. So we realize that ADHD is more and more an issue of self-regulation. So let's talk about prevalence. It's a frequent disorder. The latest studies covered 204 countries for children and teenagers. And the prevalence was 5.41%. For adults, the figure is a bit lower, between 2.5% and 3%, because a number of people no longer correspond to the criteria. Overall, contrary to what the media tend to say, the prevalence is rather stable over time. These figures of prevalence do not vary really a lot. What is certain, as you can see here on this graph, girls in pink and boys in blue, rather conventional. So the prevalence is more important, much more important in boys, but the sex ratio tends to balance over as age grows, meaning that a bit more girls are being diagnosed, and this probably for several reasons, and I haven't got time to go into details. We can discuss it in the chat later on. There's one dimension that is often associated, emotional issues. These youngsters are irritable, tend to get angry, their mood changes a lot, and they react very strongly to the environmental stimulations. And once they express their emotion, they have trouble toning down and controlling their expression. And sometimes this may be more of a problem than the motor instability. There are other disorders that are frequently associated. You should remember that when you diagnose a neurodevelopmental disorder, you should look for others because one tends to have an association of different disorders. So when you have an ADHD, you have to look for specific learning disorders, motor coordination, autistic spectrum disorders. So several disorders in neurodevelopment can be associated, and then you have more psychiatric ones like anxiety, depression, or bipolar disorders. There's this is something that is more prevalent in adults and adolescents than in children. Defiance, abuse of substances, tics, sleeping disorders, and other health issues. We tend to forget to look for other long-term diseases like obesity or high blood pressure or others that can appear. So when you talk about neurodevelopmental disorders, we tend to look at the evolution over the long term. There, they are maybe age dependent, but also context dependent. Because some parents say, I don't think my child has an ADHD because when playing on a video game, the behavior is perfectly normal. Well, this is perfectly normal because you have immediate reinforcement through the game, the play, or the visual simulations that are extremely attractive for these youngsters. And you have a reduction of symptoms in this type of context, immediate reinforcement or dual situation. Sometimes, if you do a neuropsychological test looking for attention disorders, the test is normal, but even then, you are within the criteria of the diagnosis because the attention disorders will be very strong in everyday life, like in the morning, evening, or certain school situation, where especially when they're repetitive or a bit fastidious or boring, or when you have a lot of competition, and also when the child is tired. And you must think that there are differences between the different members of the family. Mothers indicate more symptoms usually than fathers. This is probably due to the frequency of contact and that the daily tasks really are more incumbent still on mothers than fathers. So the evolution of symptoms with age go towards spontaneous reduction of motor hyperactivity. Spontaneously, this will improve with age, with or without treatment. Obviously, much better with a treatment. You have also a regression of motor hyperactivity. Aggressivity also tends to be reduced. Not so much that they're less aggressive, but when they're little, they are rather abrupt in their gestures and they have less control. And with this lesser control, for example, during recess, they might hurt or lead to a problem in socializations. The most visible things with age are distraction or lack of attention, organization, planning, feeling of boredom, looking for sensations, especially in adolescents and adults.
Et l'impatience et les tensions internes, et on le
You
voit ça
can
chez les
see
adultes.
that also impatience and inner tension. We can see that these people need to move, to get out of their meetings, to walk. These are phenomena that could be related to these impatience more than motor instability. So very quickly, the neuropsychological profiles linked with ADHD. They have trouble planning and organizing. This is executive deficit or disorder. You have an inhibition disorder. This is the same as what I showed you about the self-regulation, meaning they lack barriers. You react to your environment, but you tend to react too fast and too strongly, and especially not to take into account the context in order to adapt your response to your environment. And this is something that is very often lacking in these people, and a lack of tolerance to the delayed reward. Meaning that if you promise a child with an ADHD reward in the next 3 months, it will never work. So, as I said, it's non-specific, context-dependent, and not always related to the clinical symptoms themselves, which is why you don't give a diagnosis with the tests. You carry out a neuropsychological test to get an idea of the how they operate and to know the strengths and weaknesses, but you cannot give a clinical diagnosis with this. You have to take into account the symptoms and a wider analysis for a diagnosis. Does it persist at adulthood? Yes, but probably in an attenuated fashion. Most of the time, it's difficult to have a diagnosis that corresponds to all the criteria. Obviously, with the classification adjusts over time, but as you can see here, people mostly retain residual symptoms, or that may be a hindrance. Here, this slide is a bit heavy, but what I wanted to show you is that the raw causes of ADHD are multiple factors, and the genetic factors and environmental ones can vary in proportion. Some will have more genetic elements, others more environmental ones, some that have been exposed to some elements during pregnancy. And so you have the neurobiological and neuropsychological phenotypes, and then the symptoms are being looked at, and there's a lot of research being carried out because it's a multiple factor disorder. So to come back more precisely to the genetic mechanism, which is interesting, you should remember that it is a disorder that is strongly influenced by genetic factors. And if you look at the proportion in a population, the respective proportion of environmental and genetic factors, it's over 70% for genetic factors. Some may be common variants, the variants that everybody has. When they are in a certain situation, i.e., when several of these variants, which in isolation do not lead to any risk, when they get together, they may have an impact on the risk of developing some symptoms. This represents about 40% of heritability, and then 30% also, for example, are ADHD forms that are more influenced by rarer or low frequency copy numbers. And the DDX3X is one of them because it's part of the pathogen variants that can be either de novo or transmitted. And
sur des anomalies vraiment chromosomiques, par exemple des anomalies du
and then you have the rare chromosomal anomalies. So the more the genetic anomalies are important, the more symptoms you have apart from the typical ADHD. So you can have other disorders in neurodevelopment or other intellectual disorders. This is what I wanted to tell you. This is a factor issue, and therefore several networks are at stake. The thalamus, the frontal part of the brain, you have a lot of homogeneity and a lot of things are shown by the imaging now. We see anomalies in the connections. For example, the default networks which are associated to the resting state of the brain is going to become active when you're carrying out a task, which probably explains part of the ruptures in attention or
c'est important de parler d'adaptation de l'environnement et on va rentrer dans les traitements qu'on appelle non médicamenteux ou psychosociaux.
So now let's talk about the treatment that we can provide. And of course, for young people, we've got the intervention of parents, we've got psychoeducation to explain what's wrong with them. We've got parenting skills, training programs, what we call PMT, and then we've also got improvements to the school environment, attentional mobilization, adapted framework, contingency management, also providing sometimes personal support or even computer assistance. And that can be provided in the classroom, and that can really help. Now, the basics of parent management training programs. There are different programs. I'll show you a couple, but overall, they're using the same basis. Basically, you use the lever of the parental response to modify the child's behavior. And parents really have to pay a lot of attention to the positive behavior coming from their child, because that will boost and stabilize the child's progress. And of course, positive attention is important, and reinforcing, helping parents pay attention to the positive behavior, relying on positive reinforcement and non-reinforcement of undesirable behavior, because that can have a big impact. So if you pay a lot of attention to undesirable behavior, then that will boost that kind of behavior. It seems quite logical. And we try and reinforce parents' progress as well and boost their confidence. And we certainly help that they can come away from these programs with various strategies and just a feeling of empowerment in their strategy and feeling as a parent. I won't go through all of this. This can the information can be found on the slides, but there's a lot of information online as well. Now, just quickly on non-drug treatments. I know I have to speed up a little bit to have time for questions, but non-drug treatments is mainly with psychotherapy, so mainly cognitive or behavioral therapy, to allow the child to learn strategies and planification to solve problems. But you can also work on things that aren't necessarily targeting the symptoms, or self-assertiveness or socializations. And you can also work on remedies, for instance, to do with the cognitive or metacognitive side of things, or neurofeedback, which is also useful. I won't go into too much detail on that. There's a lot of studies out there, and I can certainly provide you with the links thanks for that. Now, educational facilities. This is something that's given by the French educational authorities. It tells you what the different possibilities are. It goes from the simplest plans, personalized help plans, which needs no recognition from the medical authorities. That's automatically set up in schools. Then you've got a more specialized and tailor-made strategy. Again, it's not too difficult to access this. You can just agree with the teachers, and usually the school doctor can validate that. Here, this is a little bit more intense. So this is a file that you have to submit to the health authorities. And then the PAI, that can be quite useful if there's no learning difficulties, but the child has to take medication, or if there are amendments that don't come under one of these four strategies. I'd now like to just talk about effectiveness data and the various CBT approaches. As for the parent management training programs, we've been able to show now that they don't have direct efficiency on hyperactivity or impulsivity, but they do reduce the risk of oppositional behavior, and they protect and they reduce the negative strategies, and they reduce that side of things. And this is something that's offered systematically now. All of the international recommendations seem to be pinpointing them and saying that they're useful because they have an overall impact on the care. And they also give parents empowerment. Now, child CBT. Studies have showed that there isn't very much a high effectiveness in the cardinal symptoms of ADHD. There's possible interest in programs combining social skills and problem solving, but it's mainly used to help with other therapies or strategies. And we run these kinds of programs where we try and tie things in with the school teachers to try and set up strategies to help the child remain in school, reduce their suffering and problems with their self-confidence. There are various different classroom presentations based on contingency management, probable effectiveness, but heterogeneous data mean that we can't really tell whether it's efficient. The CBT for adults has a better score, especially when you compare it with other kinds of treatments. The efficacy here, I would say, is average, but warning, of course, this data is for adults who were volunteers and they were really motivated to try and take part in these studies. So that's not necessarily the case for everyone. Now, for cognitive approaches, I'll be quick because it's not in favor of neurofeedback or cognitive training because programs were assessed blindly. That is to say that when you see the patient that knows what kind of treatment they are receiving, there are effects, but they are non-significant effects and they can't be applied to the different contexts. So psychostimulants, Boris mentioned these earlier. Methylphenidate, that's the only that's sold in France. But here, this is an international conference, and I'm sure you also have psychostimulants that you use related to amphetamine. It's not sold in France, some of them, but they protect from the negative sides of taking amphetamines, the flashes and the kind of addiction that you might have. Methylphenidate is totally secure. There's no antihistamine effects. prescription is fairly straightforward for ADHD. So I've set some different psychostimulants out here. There are different kinds of drugs, and if one doesn't work, you can try another. In second-line treatment, sometimes we try and use Strattera or catapressine. These drugs or medication are available, but you need to they're not officially accredited to the market, so you have to get specialist approval. Now, there are other health issues in ADHD, training, organization of care. There's a lot to do with social representations. These children are often not properly cared for. They're often from poorer families, and also personalized care is a big issue as well. Of course, there are strategies to hide all of the symptoms, but we need to try and help this move along. Thank you, and I'm available for questions.
Merci beaucoup, Professeur Purper-Ouakil.
Thank you.